Welcome everybody. My name is Daniel Canstrom, and as a professor here at BC and as faculty director of the Rappaport Center for Law and Public Policy, it is a great pleasure to welcome you to this event on behalf of myself, our executive director Amanda Teo, and our administrative assistant Alexis Albert. I believe this is my last event as faculty director, so I'm especially, my emotions are mixed, but I'm happy to be here still. My main role today is to welcome you all to this. Oh, by the way, I'm not dying or anything, just to be clear. That's a little ambiguous. I'm just starting a sabbatical, so it's a good thing. My main role today, I saw some faces there. My main role today is to welcome you all to this stellar panel of experts, academics, officials, and practitioners who are grappling with some very challenging issues of law and public policy within this most challenging period. The spark for the panel, if I remember correctly, and maybe Amanda will correct me, derived from conversations that Amanda and I were having about this government shutdown thing and how odd it was that even such well-informed cognoscenti as she and I agreed we were not entirely certain about what the hell is going on. Like, what is the issue regarding Obama healthcare subsidies and healthcare costs more generally, and policy and the subsidies and this and that. We just weren't sure. We thought we knew, but we thought that would be a good idea for a panel, because if we're not sure, there's probably a lot of other people who aren't sure. And why don't we get some of the top people in the field to help us understand what's actually going on? So after this mutual confession of ignorance, we decided to run this by our expert board member, Mary Beckman, and see if we could perhaps put together a panel that could explain more or less how we got here and more or less where we are. And Mary, with her usual magnificent verve, clarity, energy, good humor, and expertise, agreed to help, and so here we are. The panel is entitled Beyond the Shutdown: Headlines, Issues, and Impact on Massachusetts Healthcare, so we're going to be focusing quite a bit on this state, but within the broader framework of what's been happening nationally. We asked panelists to consider a very wide range of issues, some historical, some national, some quite technical, some more general, and as I said, many focus specifically on Massachusetts. I'm sure that we're going to have an enlightening panel that will leave us all very much better informed, even if perhaps still rather demoralized. Please note that this event will be is being streamed and it will be recorded. It will be followed by a question and answer session in which we always give priority to students, especially students who have gotten free food, which creates an obligation to ask a question. I always want to mention that so you can start forming your questions now. Let me just briefly then introduce Mary Beckman, our board member and moderator, and she in turn will introduce the panel a little bit more specifically and the panelists. Mary is a former senior advisor in the Executive Office of Health and Human Services in Massachusetts, where she served as acting secretary and then as senior advisor in the Executive Office of Health and Human Services in 2023 and 24. She advised the secretary and the governor on many healthcare related matters. Before that, she was chief of the Healthcare and Fair Competition Bureau in the Mass AG's office, overseeing the nonprofit organizations and public charities, healthcare, antitrust, Medicaid fraud, and false claims division for approximately 8 years. And before that, she led the nonprofit organization's public charity division. She's had a long and storied career, starting, I think you started at the age of 12, approximately, and has been a real leader in this field, and as I said, just an excellent board member. So I offer our gratitude to Mary for organizing the panel, and I will now turn it over to her capable hands, if you join me in welcoming her.
Thanks so much, Professor Canstrom, and thanks everyone for coming. It's a thrill to be here today to talk about this matter, which, when we were planning the panel, it wasn't really clear where we would be. Would the government shutdown still be on? Would it not still be on? And I think this is a minute-by-minute question. But in any event, the ambiguity deserves some clarification, and we have a great panel who's going to help us understand it better. We will start with understanding basics of the Affordable Care Act, what some of the issues are that have been at play in the shutdown, how they affect Massachusetts, what some of the policymakers in Massachusetts are working with and grappling with, and then we'll try to get into some of the rhetoric that we've heard. See if we can peel back the spin and get to the reality that may or may not be underneath that. So our panelists today, we are very fortunate to be joined by experts. Professor Chirba is the John Ford Distinguished Scholar and Professor of Health Law at Boston College Law School, and she's also a very proud BC alum. Professor Chirba has a doctorate of science in health law and policy and a master's in public health from the Harvard Chan School of Public Health, and she's written extensively on the Affordable Care Act and FDA regulatory issues. For those of you who are more deeply interested in the topic, Professor Chirba will be teaching in the spring Federal Health Law, Policy, and Politics. Celia Segel serves as Chief of Staff at MassHealth, which is the Massachusetts Medicaid and Children's Health Insurance Program together. And she's been in that role since 2024. She plays a key strategic role implementing organizational priorities, and as part of that, she oversees MassHealth's federal policy team. Prior to that role, Celia spent 8 years at the Massachusetts Health Policy Commission, where she worked on pharmaceutical pricing and policy issues. And before that, she worked on those issues for the Institute for Clinical and Economic Review, commonly known by its acronym ICER. And if you dip your toe into that waters of that pool, you will be familiar with ICER. Celia holds a master's degree in public policy from the Kennedy School and a bachelor's degree from Carleton College. Next to me is Marissa Woltmann. She is the Chief of Policy at the Massachusetts Health Connector, where she leads the agency's work on policy and research, outreach and education, and designing and procuring high-value health and dental plans for sale to individuals and small businesses on the Massachusetts Health Connector. Prior to taking on this role in the spring of 2023, Marissa spent 15 years in a variety of other roles at the Massachusetts Health Connector, and it sounds to me like she was there at ground zero, getting that organization off the ground. Prior to that, Marissa was at the Office of the Attorney General, working on the oversight of charitable organizations. As you heard, it should be close to my heart, and should be close to yours, too. She has a master's degree in public policy from Heller School at Brandeis. So many thanks to our distinguished panelists for helping us out today. And I think we should jump right in, if that's okay. To get us started, let's, Professor Chirba, could you give us a grounding in the Affordable Care Act, some of the basics, because we know that the ACA has been at the center of the federal funding debate. Maybe give us some background and then a little bit about the particular issues that have led to the shutdown.
Okay, so summarize the ACA in 5 minutes. So the ACA has been in effect for 15 years, and there are still GOP efforts to repeal and replace it. The sentiment to repeal or to at least destabilize it, I think of it as a Jenga tower. So you can knock over the Jenga tower in one fell swoop. You can also win Jenga just by taking out one little piece at a time. And the ACA is built as a set of interlocking measures. But its roots are really in President Richard Nixon's address to Congress in 1973, where he basically mapped out something very, very close to the ACA. The ideas were cultivated and assembled in the Heritage Foundation, so it's really rooted in preserve the market, but realize that people need help to buy insurance. And health insurance is expensive. I can't think of a reason why it wouldn't be expensive. So the ACA follows Nixon's plan, and it provides for Medicare, which was already in place. That covers people 65 and older. You're free to get your own plan, but it's there if you want it. There's Medicaid, which traditionally you had to fall at a certain very, very low income and also meet some categorical requirements of having dependent children and the like. And the ACA expanded that and allowed states, heavily incentivized states, and virtually required states to expand the kinds of people who could get into the plan, but also the income levels. The Supreme Court, tampered with that, decided let's make that optional. Hey, let's make that optional, which introduced all kinds of havoc into the markets. But many states over the years have expanded Medicaid. And the expansion piece is subsidized heavily by the federal government, more heavily than typical Medicaid. And then you have employee-sponsored health benefits. That was in place before the ACA, and that was, improved somewhat, but really the least affected by the ACA. And then there was this issue of, and President Nixon, being a child of the 70s, I can't believe I am singing his praises, but President Nixon said, this is expensive, people are going to need help getting it, everybody should have the individual responsibility of getting coverage, but we need to help some people pay for it. And so the ACA set up an individual market, well, at least some measures for the individual market. First, it made it easier to shop for insurance. So if somebody says, I'm on Obamacare, they're not really insured by Obamacare health insurance company. They went to an exchange and bought insurance. And just like if you go to the New York Stock Exchange and buy stock, you're not buying New York Stock Exchange owned stock, but you're buying it through that facilitated exchange of some company. So the individual market, it makes it easier to shop, it makes it easier to compare. Some of the measures to make it easier was the ability of navigators, specially trained people, to help you in this very difficult decision tree of getting a plan that fits your needs. And there were also subsidies, premium tax credits. Now, premium tax credits, not like premium, they're special tax credits, they're to help you pay for your premiums. And in 1921, in a response, not in 1921, 2021, in response to a lot of COVID difficulties, these tax credits were expanded, enhanced, to help a broader group of people to a larger degree, so that people who could not still afford coverage, they're working gig jobs, they're working part-time jobs, they have health insurance, they have jobs but no health benefits. These premiums help that piece of the market, and that piece of the market does not get the tax benefits that we get if we are insured through our employers. So it's not an unfair gift, it's really correcting a really deep failure in the marketplace. It helped uptake tremendously. And what is at issue now in the shutdown was, can we extend these enhanced tax credits to continue? Now people are saying, can we at least continue it for a year? Because if these tax credits go away, which they will in January 1, people will find the real cost of their insurance, and the real cost is significantly higher than what they've been paying for, just as the real cost of my insurance through BC is much higher than what I pay for. So it's not as if this is a gift that's being given out to this sector. It's the segment of the market. It's a segment of the market that has not been well cared for. People in the 60 to 64-year-old range who are going to get charged higher just by virtue of age. That's one thing you can charge more for. Some people are reporting their premiums going up 3 times, 8 times, etc. My son is insured through the individual market. He doesn't get credits. I don't want anybody touching his insurance. He has extraordinary health needs. I opened up the letter the other day. I was thrilled that his premium didn't go up very much, but everything else trebled. Everything. His deductible went from $250 to $750. Everything out of pocket, et cetera, et cetera. I was thrilled with this. But one thing to remember is that when people lose insurance, and many people will lose insurance under this big, beautiful bill, they will lose it in a variety of ways, including just not being able to afford insurance. That is not just a problem for them, it's a problem for everybody in the market, because there are going to be more services provided and by hospitals and providers, and they have to recoup that money from where they can get it, and they will cost shift to insured people. So I don't want to take up too much time, but basically the ACA was enacted in response to certain horrible things that were happening in the market. And now the One Big Beautiful Beastly Bill Act is taking us back there again. It's going to reinvent all of the large numbers of uninsurance, the large market perversions, and and the reasons why they were there in the first place. So it's great. It's really uplifting. So.
Well, thank you very much, Professor Chirba. That gives an overview. There's so much complexity behind even that short summary. So I think your class list for the spring semester is getting longer. Hope so. Yes. Okay, so let's hear about this, what the implications are for Massachusetts in a little bit more detail. Why don't we turn first to Marissa and then to Celia to give us an overview of how they see this from their perspective. Marissa.
Thank you, Marion. Hello, everyone. It's nice to be here. So at the Massachusetts Health Connector, we have over 300,000 individuals who currently receive advanced premium tax credits. They will all see some change in the amount of advanced premium tax credits as a result of the expiration of these enhancements. And just a word of clarification about how this interacts with the One Big Beautiful Bill Act. So the enhanced premium tax credits were enacted independently in 2021. They are set to expire at the end of this year, and the very first impacts in coverage changes under the One Big Beautiful Bill Act will also take effect for our members on January 1st, and that is the elimination of eligibility for premium tax credits for people up to the federal poverty line. Right now, health exchanges across the country like the Health Connector serve individuals up to the poverty line who are lawfully present immigrants who do not qualify for Medicaid as a result of their status. And so they have historically been able to access highly subsidized coverage, and we have 37,000 individuals who will no longer access any subsidies as a result of that. So the state subsidies that we provide on top of federal subsidies are predicated on being eligible for federal subsidies. So if you use federal, you use state as well. So kind of compounding the expiration of enhanced premium tax credits is the subsidy loss for that population. So a lot of instability in the market, and when we think about, as Professor Chirba mentioned, people who are healthier who think they could go without coverage when they're weighing the costs and benefits of having insurance, this adds to that instability where individuals with very low incomes are unlikely to be able to afford to continue in coverage. Historically, they have been lower cost. They have used fewer services and so contribute positively to the risk pool. So a lot of instability as we head into 2026 with 64,000 of our members receiving subsidies today out of about 380,000 no longer qualifying at all. Many of these individuals will be moving from a connector care state subsidized product with no deductibles, very low copays, to products with deductibles. So not only will they see their premiums increase, but they'll see their cost sharing increase. And just to give you a sense kind of for the dollars we're talking about, it's about $1,300 per year for the average individual that they'll lose in federal subsidies. State subsidies will buffer some of that, but not for everyone. And in particular, for older individuals and those who live in rural areas, they'll see the highest impacts. And some of them could see $1,300 a month added to their premium, not over the course of the year. So a really wide range and a really significant impact to people in their household budgets. Overall, Massachusetts will see over $425 million less in federal subsidy dollars coming into the state as a result of these changes. Many of them will become uninsured, particularly those low-income individuals. So I can pause here.
Sure, I think that's a lot to try to absorb. So as you are absorbing that, Celia, tell us about the MassHealth perspective.
Great. Hey everyone. So it's hard to talk about this government shutdown without talking about kind of where it comes in the wake of OB3, or the One Big Beautiful Bill Act. And it all kind of contributes to a long history that Marion was talking about in the arc of the ACA in Chapter 58. We're coming up on the 20-year anniversary of expanding coverage. So for 20 years, we've been expanding coverage to people who have been not eligible for coverage before then, to these childless adults. And a lot of the new laws that were passed in OB3 targets the same group of people who we have worked over the last 20 years to expand coverage for: immigrants, lawfully present immigrants, and childless adults without disabilities who previously were not eligible for access to Medicaid or subsidized health care. So at MassHealth, which is the state Medicaid program, we're really focused on three things right now. One is we have to implement the new federal law. So that means there's 3 deadlines over the next year. The first is October, where they changed the definitions of what immigrants qualify for Medicaid. So it used to be that if you were a refugee, an asylee, a parolee, a victim of sexual assault or domestic violence, human trafficking, you are eligible for Medicaid categorically. They changed that definition so that those immigrant groups are no longer categorically eligible for MassHealth with federal support. That's October. Then starting January 2027, we are required to implement, what many people are aware of, work requirements and 6-month eligibility checks. Work requirements, they're for people between the ages of 19 to 64 who are not pregnant, who don't have a disability, who are not medically frail, and it's TBD what that means. We have to kind of wait for guidance on what it means to be medically frail. So we are right now really, and we know people will lose coverage because of those 3 new changes in eligibility. We're estimating about 200,000 MassHealth members, an additional 100,000 connector members, so 300,000 people across the state will lose coverage because of all of the changes in OB3. In the context of Chapter 58, I think when Romney Care passed 20 years ago, at roughly 450,000 people gained coverage. So we're kind of, for the first time, contracting after many years of kind of building access to care. Because people are losing coverage, we actually have like a very interesting trust set up in Massachusetts called the Health Safety Net, which pays safety net providers for providing uncompensated care to people who are uninsured or underinsured. And so we've been really focused on boosting this health safety net right now because it hasn't, a pot of money hasn't grown since 2006. And so that's something we're very focused on in addition to implementing what we have to implement. And then the final thing is that, and we do that because oftentimes MassHealth is responsible for kind of troubleshooting and holding up like the ecosystem of healthcare around Massachusetts. And so even though, we're through federal requirements not responsible for paying for people who are uninsured, like the state looks to us to pay and help keep our healthcare system afloat. Just like last year with Steward, MassHealth played a major role in helping to keep Steward hospitals open where we could through money appropriated to us through the legislature. And I guess I'll stop there.
All right, so that's a lot of complexity. Culling from what we heard from Professor Chirba about the importance of making sure that as many people as possible are in the insurance system. There's been an awareness of that importance going back now to the Nixon administration and acknowledgement that it's important that people have insurance, not only so that they themselves can get care and be sure that that care will be paid for, but also because it means that the big pool has everybody in it. Because whoever's in the pool, in theory, is what the insurance system covers. What about people that are outside the pool? What do you think happens to those people? And I'm interested in posing to our panelists a couple of questions, observing from your comments that the changes that are either in the pipeline to happen effective December 31st with the reduction in premium subsidies and eligibility, so many people are going to fall off of the connector market, and then going into subsequent months when the changes of OB3, I think we call it, come into effect with Medicaid, more people coming on. Hundreds of thousands of people are going to sort of come out of the insurance pool. And I'd love to know from our panelists, what implications do you see from that for the healthcare system overall, either for the insurance side of it or for the provider side? Sorry, I don't want to toss that to anybody in particular. Maybe Professor Chirba, you want to start?
Sure. It's going to be devastating. It's absolutely going to be devastating. People are still going to get sick. They're still going to seek care. They're probably going to seek it much later in the progression of their condition when they could have been treated, diagnosed, much earlier, more cheaply, and with most likely a much better health outcome. You're going to have even plans that remain in place. There are going to be higher barriers with regard to just like going back to pre-ACA ridiculosity, kind of a technical term. But it's going to get it's going to get harder to have referrals. It's going to get harder to get certain medications you need. In fact, the LP faculty were having a scintillating conversation about this the other day, and I said, well, this is going to happen, and this is going to happen. And then one of my colleagues contacted me privately and started to talk about new obstacles to certain medications that even to get through BC's, I think, very generous plan. So it's going to be harder to be a doctor. There are going to be more arguments about covering things, about getting insurers to cover things. Insurers are going to have higher costs because younger, healthier people are going to come out of the pool simply because they'd like to have insurance, but they can't afford it. And then you get into the typical insurance death spiral. What would an insurance company do if it's only insuring drunk drivers? It would probably hike premiums up exorbitantly or leave the market and not insure drivers anymore. And that's what happens when we rely on private insurance so much. These insurance companies don't have to stay in the market, and if they do, they are going to have to play hardball just because their own costs are going up. There's also terrible things in the bill about making it harder to go to graduate school, to become a physician. It's very, very hard to see the logic of any of this, quite frankly. So.
Thank you. Picking up on one of the themes here, Celia, you mentioned that the state looks to the MassHealth program to kind of keep the healthcare system together, and that's sort of a non-technical way of explaining something that is full of very technical rules that people work very hard to comply with. But there is some flexibility in the Medicaid program to direct extra funds towards providers who are necessary to keep the healthcare safety net flowing, and that's, I think, what you were talking about, right? Do you see implications directly for that kind of work that the MassHealth program does coming out of the changes, both in the degradation of the insurance market and then the changes in OB3 with respect to Medicaid eligibility?
Yeah. We see, our estimates is that the state will lose about $3.5 billion in federal money.
That was a B, right?
Yeah, billion. So the MassHealth program spends about $22 billion a year. It's 40% of the state budget. About $15 billion of those dollars comes from the federal government. We expect that when all of these changes are rolled out, we'll lose about $3.5 billion. And a lot of that is because the way that the ACA was structured to get states to expand Medicaid was they provided 90% federal match on those people. So for every dollar that we spend on a childless adult without a disability, the people we expanded coverage for, we get 90 cents back from the federal government. And so in a lot of ways, what OB3 does is it kind of shifts all of those costs back to the state and says, figure it out. Because we don't want to spend those 90 cents on the dollar to cover those people. And so our estimates is when 300,000 people lose coverage who get 90 cents on the dollar, we're still going to have to pay for those people in some way. Those people are still going to need health care. There's also a lot of other kind of little financing changes in OB3 that are like complex changes to how we can tax providers. So we have taxes on health plans and hospitals that we then get help from the federal government to redistribute to the providers who have the most number of Medicaid patients. And so there's some changes also in OB3 about that component, and all told, at the end of the day, we're expecting $3.5 billion less in federal revenue for the state that we have to figure out how we kind of keep our safety net providers solvent when we're losing that much money as a state. And that's a state, that needs to be a legislative conversation, that needs to be an executive branch, MassHealth conversation, and obviously many of the stakeholders around the table who have interests at play, so hospitals, community health centers, et cetera. And one way we're doing that is through the health safety net, which I mentioned, to make sure we can keep paying hospitals, health centers for providing care to this now very much larger than we've experienced in recent history group of people who are uninsured.
One of the things that I know from talking with you guys a little bit and preparing for the panel is that the Connector and MassHealth have been putting a lot of time into quarterly meetings with stakeholders to try to anticipate what the impacts might be. And I think that's really important work. And I wondered if you guys would describe a little bit more what's involved with that and what kinds of folks come to those meetings. I'm imagining, as you talk about some of these pretty staggering implications for the Massachusetts programs, how is that news about those changes going to filter out to people that are going to be directly impacted by those changes? And I know there's a lot of work that goes on about that. Maybe Marissa and Celia, you can talk a little bit about that.
Absolutely. So we convened our first quarterly stakeholder meeting in September. We had probably about 50 people there from a lot of different organizations, so other state agencies. We had providers, we had health insurance plans, we had Mass Taxpayers Foundation that looks at state spending, we had legislators, we had folks from the governor's office, and it was a really wonderful conversation with a lot of different viewpoints and a lot of people who really came to the table looking to preserve the state's culture of coverage. There were a lot of references back to the work that was done in 2006 leading up to state healthcare reform, and a focus on our shared goals. I think everyone sees the challenges that are coming to fill a $3.5 billion hole in the system, and there were no great solutions yet, but commitment to continue taking a look at what we can do, and particularly on pulling back costs, because I think people have been struggling with costs even with enhanced premium tax credits in place, and as their access to care and coverage becomes more volatile over the next few years, I think that will become increasingly important. Celia, what would you add?
I would say right now we're trying to make it so that people don't panic. A couple of years ago we had to redetermine our whole MassHealth caseload of 2.4 million people, and we had to do a PR campaign, and we were up on billboards, and we were canvassing neighborhoods, and we were doing member communications. That was for 2.4 million people. This is going to be, because it is this narrow population of people of 19 to 64, not disabled, not medically frail, doesn't have kids. This is a much smaller population, probably closer to like 300,000 people who we need to reach, and we have to do it using many of the same tactics that we used last time. But what we want to make sure is, for instance, text messages, robocalls, mailers, notice, emails, community events. But we don't want people who are outside of that smaller population to be concerned that they are going to be subject to work requirements. So we have 67-year-olds or 75-year-olds who are on Medicaid and Medicare calling us who are worried that they're going to have to start working again. This will not apply to them. And so a lot of what we are doing now is to make sure our stakeholders know that. Who does this apply to? And then at the same time, we're building our campaigns for next summer and fall when we have to start outreaching the members who are subject to these new requirements, who might have to demonstrate that they are either working in a lot of, there's an Urban Institute study that finds that like many of these people actually are working. And we're trying to build our campaign starting next summer and fall to identify and target those people and make sure we can get into the communities that are most impacted to reach those individuals. But it's going to look different than when we were able to look at our full MassHealth caseload of 2.4 million. We have to do way more targeted outreach to the 300,000 of people who are subject.
Thank you for that. I'm getting a picture, several different pictures emerging from the last few minutes of discussion. One is the state's culture of coverage. I like that phrase. So over the last 20 years as a state, we've been moving towards program modifications and different kinds of subsidies to bring more and more people into the insurance market, if you will, or system, so that more and more people have coverage. And the changes in OD3 and in the expiration of the premium tax credits, that is the immediate issue, we anticipate are going to result in many of those populations falling out of the pool. The other picture is one of a lot of administrative costs being incurred by the state in order to respond to these changes. And for those of you who followed the theme of work requirements for various kinds of assistance programs, you'll know that generally, that the philosophical argument for work requirements may have some merit to it in some schools of thought, but the administrative reality is that when people have to reattest to their work status, the administrivia necessary to keep up with that ends up being impossible. And so even if people are eligible, they end up falling out of the system. So I think we're looking at a future with hundreds of thousands of people likely outside of the realm of coverage. And I wanted to turn for a moment to what happens to those people when they need health care. This isn't a panel that's focused necessarily on the provider world, but one of the factors that has been significant in the last 100 years, and this is EMTALA, federal law passed in 1986 that requires hospitals to provide emergency treatment and stabilization services to people who come to the emergency room without asking about insurance and eligibility. So there are at least some providers who are legally obligated to provide care anyway, and there probably are other providers who will do it because that's their mission anyway. And I'm just wondering if you have views on, or if you've heard discussion about ways of trying to address the needs of those people who are being edged out of the system through these changes.
Well, students who suffered through their first year program with me know EMTALA very well. And my worry is that emergency rooms are going to start being used as primary care clinics for everybody who's fallen off of an insurance plan, fallen out of an organized network of providers to see, et cetera. So ER rooms are going to get very, very crowded. Now, a hospital does not have to run an emergency department, so you could have emergency departments closed. You could have maternity care units closed. The whole discussion about this is just, the Democrats wanting to give free health care to all of those illegal immigrants who are here, that's a complete lie, and it's been repeated so often that with such confidence that yes, that's what it's about. It's not about that at all. And what is at risk here for emergency rooms is if they do provide care to somebody who would be covered by Medicaid if they could be, there will be a payment to the hospital. So if you're holding those dollars hostage, you're hurting the hospitals who provides that care. And very often it's just, a woman who dares to need to deliver her child. So that costs money. And we would hope that that would be done safely. So my worry is that a lot of people are going to go to emergency rooms. There's also all kinds of cuts that are not being discussed right now to Title X clinics, to access to reproductive care, to family planning care. I'm not talking about abortion at all, but I'm talking about these other restrictions that are being placed on women's health care needs. And I can't find the logic in any of this, even from a purely dollar and cent perspective. This does not make sense. Georgia implemented a work requirement. They're now saying they spent more money administering the work requirement than they spent on paying for health care. That's how costly it is. To have somebody who is a quadriplegic on Medicaid have to recertify that they're still a quadriplegic every 6 months is absolute lunacy. And I think, you can tell I have no opinion on this, but I think that all of this is supposed to get people off of health insurance. I think that's part of the plan. And when they kick it back to the states, they're also cutting educational funding from, federal dollars from states. So it's a very bleak picture. And ironically, we do have a culture of care. We do have a culture of support in Massachusetts. But the states who will be hardest hit by these changes are predominantly red states in the southeast that are always that portion of the map of worst maternal morbidity and mortality statistics, worst infant mortality and morbidity statistics, highest smoking deaths, highest gun deaths, et cetera, et cetera. They comprise over 75% of the hardest hit by these cuts in subsidies and other measures we've talked about. So.
Not a lot of happy news here, gotta be honest about that.
For me.
But, Professor Chirba, thanks for touching on I wanted to get into some of the headlines that we've seen, and one of them is the assertion that the Democrats are insisting on using taxpayer dollars to fund health care for illegal immigrants. I think I've heard that it's legal immigrants that are eligible or have been eligible under both MassHealth and the connector, and that legal immigrants are being excised from eligibility in different ways for those programs. Am I right about that? Can you guys just clarify that?
Yes, that is correct. Individuals who do not have a legal status in the United States cannot even buy full cost coverage without subsidies through the Health Connector or other marketplaces. So there are no subsidy dollars, there's no coverage in marketplaces for individuals who don't have a legal status. So all of the cuts that we're talking about are to people who, as Celia mentioned, could be refugees, asylees. The Health Connector is able to offer subsidies through the Affordable Care Act to other types of non-citizens who would not qualify for Medicaid. There's a smaller pool that typically qualifies for Medicaid who can qualify for tax credits, but we're looking at similar restrictions to refugees, asylees for 2027, as Celia mentioned, for Medicaid in 2026, so really very small pool of qualified non-citizens for any government health programs. That was kicked in for Medicare over the summer, actually, for new enrollees. And will apply to existing enrollees a little bit further down the line. But all of those types of non-citizens will be eliminated from government programs, and they are all here legally.
I'll just add that there are some states like California, New York, Minnesota that have expanded their coverage to people who don't have legal immigration status. Massachusetts is not one of those states. Massachusetts has a program called MassHealth Limited, which is essentially based off of the EMTALA, which is MassHealth with federal approval. The federal government will pay 50% of the costs, will pay for anyone who walks into an emergency room, regardless of, and MassHealth pays for that person to get emergency care, regardless of whether they're eligible for MassHealth. So that is a program Massachusetts has, MassHealth Limited, that I think all 50 states has. And then we have this other kind of wonky health safety net where we pay for providers who provide uncompensated care to people who are uninsured or underinsured.
Thank you. For those of you who are really walking in this area, the Massachusetts Health Safety Net originated as the uncompensated care pool in the wake of Antala, because before Antala, hospitals would just send all of the ambulances with poor people into Boston City Hospital and Cambridge City Hospital, which were public hospitals, and the private hospitals would just avoid providing care. And when Antala changed all of that, this state created a funding mechanism to sort of even things out, if you will. So it's an interesting history. But it's the history of socializing the cost of caring for people who can't pay for care themselves. And that's a noble history. It's very complicated, both from an actuarial and a financial perspective. But this state has always, I think, largely lined up on it's the right thing to do from a moral perspective. And there is a moral undertone to all of this. I'm not sure if we want to get into that per se, but the messaging around populations that are being dropped here is, I think, important. They're here legally and are among the poorest. Those people, I think, will find care, not all the care they need maybe, but they will find care. I do want to, there's one other headline issue that I wanted to present to our panelists. There's been some coverage that, from the Republican side, I think, I read about this in the Wall Street Journal. They had an editorial that said, essentially, if I'm trying to be fair about paraphrasing, look, the extended premium tax credits that are expiring at the end of this year are really not that big a deal, because they are not that big a percentage of the cost increase that people are going to see in their health insurance. The real issue is the underlying increase in healthcare costs. And there was some implication that that increase in healthcare costs might be related to the Affordable Care Act. And I'm wondering if our panelists could comment on whether the increase in healthcare costs underlying is, is there some proportionality? Is it a bigger factor in the overall cost increases people are seeing than the premium tax credits? And do you see any connection between the Affordable Care Act and any aspect of those increased healthcare costs?
I'm happy to start. So the National Association of Insurance Commissioners noted that states saw median proposed premium increases for 2026 of about 18%, with about 4 to 5 percentage points of that being attributable to the expiration of enhanced premium tax credits. So it is a sizable component of premium increases for next year. One thing I would also note is that the Affordable Care Act mandates that insurance companies have to spend 80% of their premium dollars on medical claims. So they have a limited amount of premiums that they can spend on their administration. In Massachusetts, that ratio is even higher. They have to spend 88% of their premium dollar on claims. If they charge more and they don't pay out for member claims, they have to submit rebates back to consumers. So premium increases are largely driven by healthcare costs, and that's consistent with what we saw in Massachusetts. I don't have a specific breakdown for how much was attributable in the just under 12% rate increase that carriers here in Massachusetts got for next year is attributable to the expiration of enhanced premium tax credits. What we do know is that because we have the Connector Care State Subsidy Program that will buffer many individuals from those increases, it was probably less of a contributing factor. I think the loss of those individuals up to the poverty line is a bigger factor when thinking about how to spread out costs across the population, because it will shrink the risk pool overall. But certainly, increases in medical and pharmaceutical costs are growing, and a problem here and a problem nationwide.
Yeah, I'll jump in. Healthcare in Massachusetts, healthcare is in a very challenging position right now, because we are seeing, at least for commercial carriers, premiums go up. The Division of Insurance approved like an 11.6% rate increase on average. They brought it down to 13.8%. Like it was, health plans came to the Division of Insurance with very high rate increases, and because of the growth in the cost of healthcare. For MassHealth, we're a state program, we depend on state revenue, so state revenue is growing at 2%, and healthcare costs are growing at 12%. And so if we're growing 10 percentage points bigger on a base of 22, more than the state revenue growth, on a base of $22 billion program, that's basically like a $2 billion problem that we have to figure out. And we have to, because otherwise we'll be spending more on MassHealth and less on everything else at a time when everyone is losing money across the board, and we're expecting to lose money at MassHealth. So it's a big challenge right now for the state to fill that gap. They won't be able to fill that gap. Everyone's trying to spread the money as much as they can across across the transportation grants we're losing, across the research grants we're losing, across healthcare money that we're losing. And the state really just can't fill the hole right now while experiencing this tremendous growth in healthcare costs.
I'll just add really quickly, the Affordable Care Act was never supposed to reduce costs. It was supposed to reduce the rate of cost escalation. And it seems to have functioned fairly well. The ACA was never thought of being a final, perfect, done deal. It was a start that would be improved over the years, which it has been improved over the years, and there's certainly more room to go. But many of the measures of kicking people off of health insurance, these are going to drive costs up. In addition to all of the other things, tariffs have not done, a tremendous amount for the, many industries, including healthcare in the United States. It's going to be harder to get through medical school. It's going to be, I could go on and on. I won't. But in terms of the measures that are being implemented in response to the ACA costing so much, it's going to make everything cost more. It just is. Frankly, I don't know why health care should be cheap when you think of all of the training that goes in. Look how hard so many of you are working to become lawyers, and just the blood, sweat, and tears, forget the tuition. One would hope that you'd be paid well for doing an important service, and certainly, health care is so important to all of us. Why wouldn't it cost something? So a lot of these are going to increase inflation and cost escalation in the healthcare sector for sure.
What's that? Yes, I was just going to say that.
Okay.
I think we have time for questions from our audience. Is that Amanda had a mic?
So we have 2 mics. We always try to begin with students if we can. So Alexa has one and I have one. We try to use the mics just so that our folks on Zoom can also hear.
So it seems like in general we're finding less reliance on the federal government, and also a lot of these blue states, there's kind of like a growing movement for healthcare as a right, free healthcare. Would it be financially possible to, fund a free healthcare as a right kind of thing at a state level rather than a federal level? Will we see that, do you think, before we see it at a federal level, an attempt at a system like that?
I think the way that states and nation states organize, finance, and deliver health care has a lot to do with their political psychology. And so our political psychology here is all for one. We worship the individual. We don't like to collect a lot of taxes and pay it to the government. So maybe you can pull it off in one state, but it's never going to be appealable to most states. And I'm not sure it takes care of all of the problems that people often say it will. So there are problems with the National Health Service in Great Britain as well.
I'll offer a comment on that I think it's a great question, and I think it's one that we all should ask ourselves periodically. In terms of the premise that we rely less on the federal government, that may end up being true, but still there's a massive amount of funding for healthcare that comes through the federal government. And one way to maybe think about your question is think about the history of the debate on the technique of block granting. There's been, perennial proposals that, if we're sick as a country of the cost of Medicaid increasing, or even maybe Medicare, let's figure out what the federal government's spending on that program today and give that money to the state in a block grant, and then the state can do what it wants with that money. Gives the state a lot of freedom, but then what happens 5 years from now when healthcare costs have continued to escalate at 6 to 12% a year, and that even if there's a inflation indexed escalator in that block grant, the proportion of money that comes from the feds versus the state over time is going to change radically, and I think that's a challenge for designing a state-based program that's not integrated with the rest of the country. I do think if anyone could do it, Massachusetts could do it. So, especially if smart young people want to get into the healthcare and government business.
Like Professor Chirba mentioned, people are going to seek care anyways, and they're probably just going to do it later when they're sicker, and so these patients are going to be paid for one way or another, whether it's insurance paying or the hospitals having to pay out of pocket anyways and just have to write it off. Have hospital systems like HCA or something gotten involved and tried to fight this lack of funding that they're going to see next year at all?
I think that's a fantastic question. And I don't know the answer. Does any of you know?
Also, one of the big debates around OB3 and the holdouts that people who didn't want to vote for it, like Lisa Murkowski in Alaska, kind of created this, it led to the creation of something called the Rural Health Transformation Grant. And that was also because of hospitals kind of being unhappy with it, which essentially is going to give money to states, probably not as much to Massachusetts, to kind of support rural healthcare providers. And so there certainly was over the summer noise. I think I don't think the American Hospitals, I don't know actually. I remember I'm not sure if the American Hospital Association came out opposed to OB3, but there certainly was a lot of noise around it and concerns around healthcare providers who care for a lot of people who have Medicaid.
Thank you all so much for being here today. So kind of jumping off that last question, obviously we talked a little bit about like these compounding crises in terms of people waiting longer to go to the hospital, hospitals kind of becoming a source for like primary care services. And so I'm curious about if there's any room, obviously we've talked a lot about like cuts in funding, so I understand that the money aspect is very, that's like a very contentious aspect of this all, but I'm wondering if there's any room or like thought that the state has given to kind of like innovative practices in terms of like increasing support to like community health centers and those sorts of facilities in terms of trying to like preemptively mitigate like what's inevitably going to be happening in hospitals. So yeah, I'm just curious if like, I'm sure the state has given thought to that, but if you could talk a little bit about like what are some of those ideas and like if there's work that other states are doing that Massachusetts is trying to like emulate, or I'm just kind of like curious about that aspect.
Yes, and I would say that the stakeholder forum that I described earlier is the place where some of that thinking, which is very nascent, is starting to occur. And I think the funding question is really one of the big ones, and one of the things that we've used as a tool as we think through the impacts of some of these laws, or thinking about the very straightforward loss of dollars, loss of coverage, and then there's another bucket of changes that are more administrative in nature, things that can be solutioned around, but that loss of dollars, that loss of coverage, I think is one where the legislature would need to be involved in particular, and hearing from all of those different stakeholders and understanding where there are resource constraints within the system already, and how we address those as well as the cost implications. I think it's going to require a lot of collaboration that's just starting to get underway.
Yeah, and I'll add, community health centers are like absolutely a part of this conversation. We do pay community health centers through this health safety net for providing care to the uninsured, and so people, if they know they can go to a community health center for primary care, we will pay for that care for that person. And then we also pay for outpatient care. Something like, according to the policy commission, like 90% of physicians are affiliated now in the state with one of the 7 major systems. Physicians are really getting affiliated across the board, and so I do think there's a lot of outpatient hospital sites that people will still be able to get care at through this mechanism of the health safety net. And just one more thing is this past summer, the governor signed, or in September actually, the governor signed a cash infusion of $235 million to the health safety net, with $35 million going to community health centers, and I think $77 million going to safety net providers, not community health centers, acute hospitals, and $22 million kind of going based where there is need. And so there is a lot of conversation right now around how we support community health centers and hospitals, not just emergency rooms, but outpatient hospital care.
If I could just add briefly, 20 years ago, no, I'm not that old. Long ago and far away, actually a student and I co-wrote an article saying, it was entitled Setting the Stage for National Reform, and it was all about Massachusetts health reform. And a distinctive feature of MassHealth reform was getting all of the stakeholders around the table and to buy in. I always thought that that the employer mandate component of the state law would fall to an ERISA challenge, ERISA preemption challenge. Nobody ever challenged it though, because they did such a good job of creating political buy-in. And John McDonough, who was key in that, was actually brought down to Washington to help with the Affordable Care Act. And so Massachusetts, if anybody's going to pull it off, I do have confidence we will. I'm glad that we live in a state that actually wants to pull it off, because I don't think other states necessarily have the will to try to figure this out. So.
I'm curious on under the umbrella of safety net providers, on the extreme end of it, when there are like private providers like Steward Healthcare who provide important care but then fall under or go into bankruptcy but provide care across multiple states. What mechanisms for enforcement are there for states like Massachusetts to sort of fill in the gap when there are poor community members who rely on that care, but then there's a gap of not a community health center, but a large provider going into bankruptcy, but receiving these subsidies, but for themselves, of course, the costs are going up and it's not feasible for private equity to keep doing this business. And just what the role of the increasing presence of private equity in healthcare, what that impact might be on the poorest and people who need the care the most.
Can I take that our students don't all ask hard questions?
Yes, I was just going to say, I want to take, if I might, the moderator's prerogative to kind of try to peel apart the richness of what you put on the table. And I want to put it to one side, not to, because I think it could be a whole other panel, the implications of private equity in healthcare. And I want to ask if any of our panelists could comment maybe on some of the more specific things you raised about safeguards around, I think what I heard is like safety net payments that the state is giving to providers, kind of making sure that it doesn't leak out into subsidizing care in other states through an indirect bankruptcy mechanism. Is that right? More or less. So I will say that I believe the health safety net operates based on it's almost like a claims function. Yeah. And so there are some safeguards. I would say it's the way the system was designed. It wasn't designed as a safeguard to prevent leakage of Massachusetts subsidies into other states or into the hands of private equity, but based on care actually provided to people who are uninsured, underinsured. There's a claims-like mechanism for essentially making that claim and getting paid based on that, right?
Yeah. Yes. And I think, well, I guess I'll say two things. One is the way our safety net pays is that we pay, it's a finite pool of funding that's based off of a tax on hospitals. So like, well, all hospitals, the health plans, and with state contribution. We pay 100% to community health centers for the care they deliver and the claims that they submit to us. Then we pay 85% to acute care hospitals. And then whatever is left, we spread out to acute care hospitals with the highest Medicaid population. We have like a tier system. And then whatever is left, we spread out in a claims-based way to other hospitals. And so that's the way we do it, to kind of focus our dollars on the highest need safety net providers. And I guess in the wake of the Steward, there was a new law that was passed to increase the oversight of the Health Policy Commission and their market oversight. I think the jury's out.
Right, I'll say on that, the private equity question is really a great one, and it's probably a whole other panel, just to encourage your exploration of that. The new law does give the Health Policy Commission additional responsibility and authority over certain kinds of transactions in healthcare that involve private equity backers. But that's just a scratch on the surface. I think throughout, not just healthcare, but for a variety of reasons, private equity is getting more into spheres that involve investments in what I would call critical social infrastructure. And one could ask the question about why is that happening, and I think it's related to the lack of access to traditional credit. And why is that happening gets you back to what's the financing mechanism behind these healthcare transportation, very complicated and really important to unravel, and maybe the next panel, maybe the next panel. Any comments on that that are more intelligent than that? That's just going to kick the can, but we will get there. Other questions?
I know we are winding down at the time, and I just wanted to, first of all, thank Professor Chirba, Marissa, and Celia for helping us all be a little bit more sophisticated and nuanced in our understanding of health policy. And I'm particularly grateful for some new vocabulary that I'm learning, including OB3 and ridiculosity, which I'm going to use quite often. And I also wanted to thank Mary Beckman for once again lending us her tremendous skill as a moderator, guiding a conversation like this one, and knowing which questions are going to spark learning and inquiry. That is a really difficult task and also really an art. And Mary practices it with such beauty and deftness, and we're really appreciative of our advisory board members. But speaking of the art of questioning, I love that Professor Kanstrom gave me credit, but actually this panel was completely inspired by his questions. I loved what he said to me and Mary, that even as a law professor, he just didn't have, and I underscored this, any idea of what the hell is going on in the shutdown debate. And I think this moment of curiosity sort of really captures Professor Kanstrom perfectly. The Nobel Prize laureate and Egyptian writer Naguib Mahfouz said, "You can tell whether a man is clever by his answers, and you can tell whether a man is wise by his questions." And by that measure, Professor Kanstrom's wisdom has really guided the center for the past 7 years. Since 2018, he has led the Rappaport Center with clarity, with creativity, and care. He has shaped our conversations. He's helped us think more deeply about law and public policy, about our shared responsibility to the public good, and he has just asked fascinating questions that have generated not only great panels like this one, but also initiatives like the Senior Fellowship Program that we wrapped up last week with Carol Rose. So as he prepares to pass the baton in January to Professor Pat McCoy, who I think will also bring her own generous spirit and leadership to the center, I just want to take this moment on behalf of all of us here at BC Law and also the Rappaport community more generally to thank him very sincerely for your wise questions, for your steady guidance, and your remarkable service to the Rappaport Center and to BC Law. Thank you so much.